Hello class, I'm going to start our discussion on Chapter 12, which deals with hematology, the study of blood, and specifically hematopoiesis, which is the production of blood cells. We can change that name from hematopoiesis to something like erythropoiesis when we are talking about the synthesis of red blood cells specifically. Now, some of the material that I am presenting here in Chapter 12 is going to be found in our next chapters, like Chapter 13 and 14. I was basically trying to make a logical approach, so you might need to read some of the other parts in these subsequent chapters to find the information. Let's review whole blood. Whole blood is 55% plasma and 45% formed elements. Now the plasma components I will address later on in a future segment, but plasma for right now is mostly water, and there is about 7 grams percent plasma protein. Maybe that's a new term for you, grams percent. That means that's the number of grams dissolved in 100 milliliters of whole blood. So plasma protein isn't the only solute, of course. There are other solutes like sodium, calcium, etc. I'll address plasma in a later segment. Right now I'm going to focus on the formed elements. Primarily I'm going to focus on the red blood cells, which are the most abundant of the formed elements. And then I will talk about white blood cells. Platelets and manipulating hemostasis is discussed in Chapter 13. Where hematopoiesis occurs actually changes in the body as we develop. When we are talking about an embryo, hematopoiesis happens in the yolk sac. When we are talking about a fetus, hematopoiesis shifts to the liver and spleen. And then shortly after birth, hematopoiesis is again going to change its locale and move to the bone marrow. Now, again, depending on how old you are, if you are under age 20, hematopoiesis is occurring in the bone marrow of your long bones in the medullary cavity. But as you approach age 20 and onward, everything is downhill, at least it seems like that way. Hematopoiesis after 20 will shift to the iliac crest, the vertebra, and the sternum. So you lose your red marrow in your long bones, and it turns into yellow marrow, which is basically fat. Now let's go back to the actual act of hematopoiesis. Hematopoiesis begins with a stem cell called a hemocytoblast. It is considered to be multipotent, which means when it replicates and divides and gives birth to daughter cells, they can only turn into some sort of blood cell. They can't turn into an osteocyte, which is a bone cell. They can't turn into a hepatocyte, which is a liver cell. Multipotent, again, means that it replicates, divides throughout your lifetime. It's a stem cell, but its daughter cells can only pick one of the blood lineages. As the hemocytoblast divides, it gives birth to new daughter cells. These daughter cells will turn on selective genes and turn off others. And this means they will then progress through a specific lineage to become differentiated. They can differentiate into either erythrocytes, which are red blood cells, or the granulocytes, which are neutrophils, eosinophils, and basophils, or monocytes that turn into macrophages, or they could turn into megakaryocytes, which bleb off packages of clotting factors within formed elements known as platelets. Or the multipotent stem cell can give birth to daughter cells within formed elements known as your white blood cells that differentiate into T cells and B cells. These are part of your specific immunity, of course. Now, look at this picture. Initially, the multipotent stem cell will replicate and divide and give birth to two basic types of daughter cells. These are called, quote, colony-forming units. One type of colony-forming unit is the myeloid stem cell, and the other type is the lymphoid stem cell. And the lymphoid lineage will differentiate into T cells and B cells. And the myeloid stem cell line will give rise to all the other types of formed elements. The red blood cells, the nonspecific immunity white blood cells like neutrophils, eosinophils, basophils, monocytes, and also the megakaryocytes. As you are looking at this screen, as the lineage progresses from left to right, the cells become more and more differentiated. The multipotent stem cell is determined, meaning it is already selectively turning on specific genes that allow it to give birth to some daughter cells that will ultimately become some type of formed element. But the early daughter cells are not differentiated. You could not look at them and discern what kind of blood cell they are going to be, not until the end of the process, where they are fully differentiated, can you look at an eosinophil and distinguish it from a neutrophil. I'm turning our focus on erythropoiesis for a moment here. Erythropoiesis takes about 5 to 7 days, and as I said on the previous slide, we start with a hemocytoblast. It will replicate and divide. Some of the daughter cells will enter the myeloid stem cell line, and then some of the daughter cells will progress through the erythropoiesis lineage. They will turn into a proerythroblast. It's destined to become a red blood cell. It is more determined than its mother cell, the hemocytoblast, but still not differentiated. As the immature red blood cell differentiates, it is actively synthesizing hemoglobin up to the reticulocyte stage. I will discuss the components needed for the proper synthesis of hemoglobin in a bit. The red blood cells are sacs of hemoglobin. It is the most predominant substance that they have inside of them. There are other solutes, of course, but primarily the red blood cells have a high concentration of hemoglobin. While it is the reticulocyte that is actually released into the circulation, it should be no more than 1% of all the circulating red blood cells. If we see an elevation of a reticulocyte population or a reduction, this is a sign of pathology. More to come on this. It takes about 1 to 2 days for the mature reticulocyte to lose its remaining endoplasmic reticulum and ribosomes. The endoplasmic reticulum and ribosomes are a reflection of the reticulocyte, making hemoglobin up until the very last moment of release. Red blood cells, of course, lack organelles when they are fully mature. They lose their endoplasmic reticulum. They certainly lose their nucleus very early on in their differentiation, and they lack mitochondria. And that's really important because red blood cells are supposed to carry oxygen. And if they have mitochondria, well, then the very oxygen they are supposed to be transporting to give to the tissues of the body, they would themselves consume. So red blood cells lack mitochondria for good reason. It also means they lack aerobic means to synthesize ATP. That means they will have to use anaerobic means to make their ATP, like glycolysis or the pentose phosphate pathway. It is worthy to discuss the significance of a reticulocyte count in a healthy patient. First, let's recognize that when the number of red blood cells and hematocrit decrease, the percentage of reticulocytes may appear falsely increased compared to the overall number of red blood cells. In order to get a more accurate assessment of bone marrow function, the calculated reticulocyte percentage is often corrected with a calculation called a corrected reticulocyte count or a reticulocyte index, RI. This calculation compares the patient's hematocrit with a normal hematocrit value. The reticulocyte count is a reflection of recent bone marrow activity. If your bone marrow is responding appropriately to the demand for increased numbers of red blood cells, then the bone marrow will allow for the early release of more immature red blood cells, increasing the number of reticulocytes in the blood. If you bleed or hemorrhage, then the number of reticulocytes will rise a few days later in an attempt to compensate for the red cell loss. If you have chronic blood loss, then the number of reticulocytes will stay at an increased level as the marrow tries to keep up with the demand for new red blood cells. If your marrow is unable to keep up or is not functioning normally, then the number of reticulocytes may be normal or only slightly elevated despite demand, but will eventually decrease due to lack of adequate production. If the number of reticulocytes is not elevated when you are anemic, then it is likely that there is some degree of bone marrow dysfunction or failure and or deficiency of erythropoietin. I will discuss erythropoietin in just a bit. Patients who move to higher altitude may have increased reticulocyte counts as their body adapts to the lower oxygen content of their new location. Smokers may also demonstrate an increased number of red blood cells and reticulocytes. Reticulocyte counts may be increased during pregnancy. Newborns have a higher percentage of reticulocytes, but the number drops to near adult levels within a few weeks. Reticulocytes, just to say it again, they are a young erythrocyte. The cytoplasm still contains a large number of ribosomes, an endoplasmic reticulum, and RNA, of course, which is being used during translation to make the hemoglobin chains. Ribosomes have the ability to react with certain dyes, such as brilliant cressyl blue, or a stain known as new methylene blue, and it forms a precipitate which stains blue. This reaction occurs only on staining of cells that are still alive and not fixed. Therefore, this is called supravital staining. I'm showing a picture on the slide of some reticulocytes. Reticulocyte count is an indicator of bone marrow activity and is used to diagnose anemia. The number of reticulocytes in peripheral blood can be increased or decreased, like I said, for various reasons. Reticulocyte counts and percentages can change. True, I've addressed that. A decrease in numbers can be an indication of anemia. It could be an indication of bone marrow failure, aplastic anemia, or hypoproliferative disorders. An increased number can also be an indication of anemia, as the body is trying to compensate by producing more red blood cells by releasing more reticulocytes into the bloodstream. Obviously, just taking the count of reticulocytes is simply a marker to detect a change. It is just an indicator, and more tests would have to be done to actually find out what's going on in the patient. What else do we know about red blood cells? Here are some RBC indices. This is information that you should know as future clinical care providers. When we are speaking of H&H, we are referring to hematocrit and hemoglobin concentration. Hematocrit, of course, is the proportion of red blood cells to whole blood. What you do is you measure the column of red blood cells in millimeters, and you divide that by the entire height of the whole blood column that's also measured in millimeters, and then you get a ratio. The normal ratio for hematocrit for men is slightly higher than for women. They have testosterone, and that is a steroid hormone which affects the bone marrow, and therefore men have a higher number of red blood cells. Men have a hematocrit of about 45% and women slightly lower than that at about 40–42%. Hemoglobin concentration is the amount of hemoglobin in 100 milliliters of whole blood. There are machines that we use to determine hemoglobin concentration in the clinical laboratory called hemoglobinometers. The standard value of hemoglobin concentration is about 14 to 16 grams per cent in whole blood. Again, males are going to be slightly higher than females. What is oxygen carrying capacity? The way we transport oxygen in our whole blood is in two ways. One, dissolved in the plasma, or two, bound to hemoglobin. The amount of oxygen you can dissolve in your plasma is actually very, very little. Dissolved oxygen is not our primary way of carrying oxygen. Our primary way of transporting oxygen is through hemoglobin. The more hemoglobin you have, the more your oxygen carrying capacity. If you have less hemoglobin, you are going to have reduced oxygen carrying capacity, which is the definition of anemia. For every gram of hemoglobin you have, you can carry 1.34 milliliters of oxygen. Let's say a patient has 15 grams percent hemoglobin. If you multiply that grams percent by 1.34 milliliters of oxygen, you will get the units of about 19 to 21 milliliters of oxygen per 100 milliliters of whole blood. You do not drop the 100 milliliters of whole blood from your calculation. We sometimes abbreviate this as saying 20 milliliters O2%, where the percent represents the 100 milliliters of whole blood. Continuing with more red blood cell indices. How large is a red blood cell? Well, the volume of a red blood cell is oftentimes designated as mean corpuscular volume, or MCV. A red blood cell is about 80 to 100 cubic microns. This is the same as saying a femtoliter. If I were to take a single red blood cell and crack it open and measure just the hemoglobin in a single red blood cell, I would get something about 32 micrograms, or another way of saying that is 32 picograms. A picogram is 10 to the negative 12th. If I were to take a single red blood cell and compare how much hemoglobin I have compared to its volume, this would be a grams to volume ratio, or a reflection of the solute to solvent ratio. And this is MCHC, mean corpuscular hemoglobin concentration. Okay, for example, I just told you in a single red blood cell there are about 32 picograms. If I divide that 32 by the mean corpuscular volume, I'm going to get roughly 32 to 34%, right? Because mean corpuscular volume is something like 80 to 100 cubic microns. So let's just pick easy numbers. 32, that's the mean corpuscular hemoglobin, divided by 100 would give us 32%, right? But our mean corpuscular volume is probably slightly lower than 100 cubic microns. So 32 divided by a slightly lower value, let's say 95 cubic microns, would give us a mean corpuscular hemoglobin concentration closer to that 34%. Mean corpuscular diameter is how wide the red blood cell is. It's somewhere between 7 to 8 microns. Lastly, color index. Well, that's just basically a way to say how red does the red blood cell look. It's an indication of how well packed it is of hemoglobin. There's a normal range, of course, but color index of 1.0 tells us the red blood cell is adequately filled with hemoglobin. I want to tell you about the erythrocyte sedimentation rate test, or ESR. Basically, this is a test where you get a rack, and I have the rack shown here, and some capillary tubes sitting in the rack, and you take a whole blood sample and you put some saline in it to dilute it, and then you make sure it's mixed. Then you put it back in the rack and you wait for 1 hour. And what happens is the red blood cells are going to fall due to their density. They're going to settle down to the bottom of the tube. You are measuring the distance that they fall in 1 hour. If you look at the bottom right picture, you are seeing that the height of the red blood cell column has dropped from the top. What are normal ESRs? In males, their red blood cells should drop about 20 millimeters in 1 hour. In females, it will be a little bit faster. They are going to drop about 22 to 25 millimeters per 1 hour. That's because they have fewer red blood cells and there will be less of a rouleau formation and less resistance too. Okay, so what is a rouleau formation? The top picture here, shown with the red blood cells stacked like coins, is showing you a rouleau formation. Now here's my analogy. Let's say you are making jello. You've heated up the jello and now it's starting to congeal as it cools. If you were to put pennies on top of the jello, they would fall down to the bottom of the pan. But let's say you have a stack of pennies that you put on top of the jello compared to just a single penny. Which one would fall to the bottom of the pan faster? Do you agree that the stack of pennies would actually fall faster to the bottom of the pan than an individual penny? Well, that's a rouleau formation. Red blood cells can stick and stack together. This is not clotting because clotting deals with platelets. That's something totally different. What does the rouleau effect tell us? There is something changed about the red blood cells that allows them to stack together when they form this rouleau formation. They will actually have faster ESRs. In a healthy individual red blood cell, they don't really stack or settle very much in an hour. In some disease conditions, increased production of fibrinogen and immunoglobulins cause the red blood cells to clump together, to stack up, and form this dark red column known as the rouleau formation. Again, everyone has an ESR, but not everyone has a condition where the red blood cells would have a rouleau formation. That formation may or may not occur. The ESR is neither very specific nor diagnostic, but it can be used to follow the progression of certain diseases, including sickle cell anemia, some cancers, inflammatory diseases such as rheumatoid arthritis, just to name a few. When the disease improves, the ESR decreases, fewer millimeters per hour. ESR can be elevated in iron deficiency anemia. That means faster ESR, more millimeters per hour. And menstruating females sometimes develop anemia and show an increase in ESR. The ESR can also be used to evaluate a patient with chest pains because the ESR is elevated in established myocardial infarction due to the release of cellular signals from the dying cells, like C-reactive protein. But ESR is normal in angina pectoris. That means chest pain without MI. Similarly, it can be useful in screening a female patient with severe abdominal pains because the ESR is not elevated within the first 24 hours of acute appendicitis, but is elevated in the early stage of acute pelvic inflammatory disease or ruptured ectopic pregnancies. Even though it doesn't really tell us much, the sedimentation rate is still used clinically. Let's practice. If a person is a diabetic, would you expect a slower or faster sedimentation rate? You would actually get a slower sedimentation rate, fewer millimeters per hour, because the plasma is more viscous due to the increased glucose. It's thicker, and so the sed rate would be slower in the diabetic. What about polycythemia? Those are going to be slower, so they're not going to have as many millimeters per unit of time. Like I said, average values in healthy men are roughly 15 millimeters per hour or so. Women are going to be slightly faster because there is less resistance to the drop in their red blood cells. Let's review some terminology. Chromasia is an indicator of mean corpuscular hemoglobin. I'll say that another way. When we talk about red blood cells being normochromic, it tells us that the red blood cells look adequately red enough, meaning that they have been adequately filled with hemoglobin. If a red blood cell looks hypochromic, then that tells us that they look pale and that they are not adequately filled with hemoglobin. Hyperchromic, that tells us the red blood cell might be overly filled with hemoglobin. When might that happen? Well, I'm going to tell you about a condition known as hereditary spherocytosis when we get to our red blood cell pathology lecture. Anisocytosis refers to cells of abnormal size. If we say a cell is normocytic, then it's a cell of normal size. The mean corpuscular volume then would be something like 80 to 100 cubic microns. If we say a cell is microcytic, then that means it's too small. If we say it's macrocytic or megalocytic, that means that it's too large. Poikilocytosis is a term to refer to cells of abnormal shape. So we could see red blood cells that are perfectly round, and the term for this is spherocytosis. Red blood cells are supposed to be biconcave, of course. Sickle cell is when the red blood cell looks like a half moon or crescent shape. An echinocyte is a red blood cell that looks like they have little spines like sea urchins. So these are some good terms that we use when we're looking at red blood cells. Hematologists will use these words to describe how normal the red blood cell is. Is it normochromic, normocytic? Is it hypochromic, microcytic, etc.? Let's continue with some more red blood cell facts. When we do a red blood cell count, we are going to typically count about 5 million red blood cells per microliter, or cubic millimeter. If you were to make a period at the end of a sentence, the volume of that period inside that little dot that you drew, there would be approximately 5 million red blood cells. It is the most abundant cell type in your body. 1/4 of your 100 trillion cells is from red blood cells. As I said in the previous slide, red blood cells are biconcave. This will help increase their surface area for gas exchange. It also allows them to bend as they go through small capillaries. Even though a red blood cell is only 80 to 100 microns, oftentimes the diameter of capillaries is smaller than that. In the top right picture, I'm showing you a red blood cell that is literally folding over on itself in order to squeeze through the capillary bed. Red blood cells, again, are membranous bags of hemoglobin. Hemoglobin is the most abundant substance dissolved in the watery cytoplasm, and the hemoglobin, as I said before, is going to help carry our oxygen. Carbon dioxide will also bind to hemoglobin, but in a different place. It does not bind to iron. In the bottom right picture here, you are seeing a man in a bathtub, and this is to represent a steady state. We have red blood cell formation in the bone marrow. It enters the circulation as reticulocytes, and then they mature in 1 to 2 days. And red blood cells live for about 120 days, at which point they have sustained so much damage that they cannot get the damage removed. So why do I have a picture of a man in a bathtub? Well, for my physiology students, I tell them, here's your homework for the night. Go home and start your bath, start the water, have the drain engaged so that the water accumulates in the tub. Once the water is halfway up your tub, I want you to open the drain, and I want you to match the water that is coming in to the amount of water that is leaving the tub. If you match this, then your level of water should not change, right? But if you left the water running overnight, would the water in the tub be the same water from the night before? No, but the level of the water would be the same. The water should still be halfway up the tub. So that's what we mean by steady state. The production is matching the removal. If I were to take your red blood cell count today, and then a month from today, I should still have roughly the same red blood cell count. But clearly, the red blood cells in a month will not be the same red blood cells you have today. What produces or stimulates the red bone marrow, the hemocytoblasts, to produce more red blood cells? Well, erythropoietin is a hormone, and it mostly comes from the kidney, about 90%, and about 10% is going to come from the liver. The kidney does have the ability to detect oxygen levels in the blood. Another way of saying this is the kidney has sensors that will detect hypoxemia. That means low oxygen content in the blood. The kidneys, and token amounts from the liver, release erythropoietin in response to hypoxemia, and this will target the hemocytoblasts, which would increase the number of daughter cells. And the erythropoietin would stimulate more of those daughter cells to go into the red blood cell lineage. Erythropoietin promotes stem cell mitosis and promotes the release of reticulocytes. So we would see an increase in the retics in the circulation. Then, in about 5 days, we would see an increase in the actual red blood cell number. There is synthetic erythropoietin that has different names like Ecrit, Eprex, Dynapo. And it is of concern because, of course, in the athletic world, a person can dope and inject more EPO. This would mean that they would have a higher hematocrit, and if we are talking about running in a race or cycling in a race, then of course the person who has more oxygen carrying capacity means that they can stay in an aerobic state longer and produce less lactic acid. So that might shave seconds or even milliseconds off their time, and that makes a difference when you are racing, of course. Now we have human recombinant EPO, which is really difficult to detect in doping panels. In an effort to abate this doping problem, a lot of athletic venues are saying, well, we recognize that you might be doping, and we can't detect it. So we're putting a limit on the hematocrit. Just as an example, if you have a hematocrit of more than 55%, let's say, then you cannot run or cycle in this race. This slide is just to highlight again that the kidneys are responsible for detecting the levels of oxygen. If the levels of oxygen in the blood decreases, the kidney will detect this and increase the amount of erythropoietin. This will then stimulate more mitosis of the hemocytoblasts and promote the daughter cells to go through the red blood cell lineage, and more reticulocytes will be released into the bloodstream. Why do I have a picture of a mountain up here? Well, obviously people who are living at higher elevations are going to have less oxygen content in their atmosphere. The kidneys would detect this, and they would increase the amount of erythropoietin released to increase the red blood cell synthesis. People who are living in higher elevations are going to have a higher red blood cell count. This is an adaptive response and is not seen as pathological.